Joey,
Jubilee Bonnie rate for June is already sold out.
Yeah, probably
And then if
sold
we
out
can
right
make sure
away.
we've got
Yeah.
everyone on mute, that'd be fantastic. Cool. Dr. Rob, without further ado, over to you to give the guys an update on virtual consults and growing with KBMO.
Thanks so much, James. I greatly appreciate the time and the opportunity to share some insights. And it's been a enjoyable, glamorous relationship using KBMO to really take my patients' outcomes and my practice potential to new levels. So I want to share some ideas on how to incorporate the KBMO tests and grow and enhance our virtual consults. If the last 3 or 4 years in healthcare have taught us anything, there's tremendous opportunity in doing things virtually with patients. What I found has happened is that it allows people, I live in New York, if you didn't notice, there are times where weather is bad. So that gives you opportunity for virtual. New York is a big state. There may be people, I'm right by the city, upstate, an hour, 2, 3, 4, even 5 hours away, that I want to be able to share some ideas and be able to help. Also, it's enabled my practice to grow online, nationally, and even internationally. So these are some opportunities that I think all practitioners really want to harness. In that also, I think the KBMO, because they are a finger stick and they're seamless and they have such high accuracy, are tests that you all would want to put into your practice armamentarium and base your diagnosis in a functional medicine light. So let's dig in. Let's go over a couple of ideas. So I really like this quote. I think it kind of says it all. In an age where the average consumer manages nearly all aspects of our life online, it's a no-brainer that healthcare should be as convenient, accessible, and safe as literally online banking. There is virtually nothing that I can't do with this phone. I always wonder, and when I ask my dad, who's in his 90s, Dad, did you ever think that this was going to be the means in which we could communicate? This was going to be the means in which we could deliver, understand, and ascertain healthcare. And he's just like, he still can't believe that we got past the Snoopy era. So if you're transitioning into a virtual practice, clearly you're here, but I'm going to share some specifics on how to transition. First step is, getting on this webinar. That's great. The second step will be going through a few things that I strongly recommend that I've seen that's worked in my practice, and taking every week another course, if you will, on how to make virtual more seamless and online more seamless. So first, what are the benefits to the doctor? We always talk about the patients, and well, we should, but what benefits did the doctor have from adding a functional medicine nutrition online? Number one. Hey guys, could you do me a favor? Could you just turn mute your sound? Everybody can hear you.
Mute everyone, please.
Thank you so much. Could you please mute yourself? Everybody can hear you.
Yeah, I've just done it for everyone.
Okay. Number one, am I muted now?
No, you're good.
Okay. Thanks, James. So number one, improve patient care. It does lead to a better experience for patients. They're comfortable. They're in the confines of their home. They may be even in the confines of work. You can embrace more freedom. I mean, it's really cool to have your cup of coffee in the morning, 5 minutes before you sit down and go to work. There's no travel expense. There's no travel experience for both you and the patient. I'm a chiropractor, so in that's a difficult thing because I need these. However, in my other set of hands, my functional medicine hands, I don't, and I need the laptop, I need the phone, etc. It also enables you to expand your influence. I have to say, as a practitioner, I'm really happy that I was able to connect with KBMO because it gave me tests that I could use as a baseline experience and use of a diagnosis so I could get to more people. You build your profile, if you will, you build your influence. And the reason we became doctors is to help people. We're only typically able to help the people right around us, a small little cadre. But the ability to implement virtual lets us expand, nationwide, international, as I said before. It actually gives the doctor more time, not just more free time, more time if you want to prepare for the encounter, to prepare for the exam, to prepare for the virtual consult. And it's obviously quite convenient. So how do you do it? That's the big thing. James and I were talking about this. I mean, what are these implementable steps that you need to do? Well, number one, you need to announce your new services. Doctors, we're great at seeing patients. We're not always marketing gurus, but here's some easy steps to let everybody know what you're doing and announce your new services. Number one, tell your existing patients and patients who are using and referral sources. Let them know that you're doing some work that's online and virtual. Number two, email blast, constant contact. I happen to use that one. There's some email chimps. Let everybody know that they have a virtual opportunity. Those are for your existing patients. Those are for your existing referral sources. You want to know something? Somebody once said it was worth the whole webinar. There is gold in our files. There's people there that we're not contacting that are just looking for something different, and virtual may be that. Number two, if you will, website. Everybody's website should say that you do virtual consultations. People still Google websites. I went on the KBMO website this morning. Social media. I know that's a whole nother tundra. That's, the black box. However, those who are social media savvy can definitely captivate an audience by utilizing social media, whether it's YouTube, whether it's Instagram, whether it's Facebook. And I'm seeing more and more KBMO videos. I think, and I'm going to talk to James about this, maybe we'll make some videos on how to implement or how these tests work from a virtual consult. So if you don't have the time to make the video, you can utilize those. This also gives you the opportunity when you announce your new services to reach out to other practitioners and organizations. Again, I live in New York. I can now reach out to someone in Connecticut. I can reach out to someone in Delaware. I can reach out to someone in California. So I can reach out to organizations to let people know about what I do, where obviously geographically there was a difficult thing to come and take a plane to my office. Online bookings. You patients have the ability to schedule a consult. It's seamless. You don't even have to utilize staff for that if you don't want. What you must have is like what we're using today, a video conference, ergo a Zoom. Zoom will do it. It's HIPAA compliant. One of the things that I really like about the how to do is the test and don't guess, or test and not guess. So when it comes to utilizing the KBMO tests, you have two options, and I'm not going to tell you how to do it. I do it both ways. Number one, send them the test prior to the consultation. So send them the gut barrier panel, the FIT 176, the cardiovascular inflammation test. Have that done. Send them 2 weeks in advance, get the feedback, get the results, and be ready at the initial consultation. Some other instances where I need a consult to decide if those tests are enough or I want more, you can then test after the initial consult. What I like to do is I usually do, if I can share some insight, a 15-minute consult. I call it a discovery call. And in the discovery call, I'll make all the suggestions and lay out a plan, etc. Always make sure you have a follow-up appointment. There's too many patients that are in outer space, myself included, that I'm not touching, that I'm not in contact with. The typical treatment programs with these tests would be about 3 to 6 months because it gives you the opportunity to retest. You want to test, you want to treat, and then you want to retest so you can show the improvement, and you always want to use the same baseline test. I am a brick and mortar. I'm also a brick and mortar online. I'm mixed. I still see patients. I saw patients from 10 to 12:30 this morning. I actually had a patient online at 9 o'clock. I have some patients now online. So I'm a mix of a brick and mortar. So my suggestion is don't shut your brick and mortar off if you have it. Just start doing some online. My suggestion is do 1 hour a week online. And when you get your next second, third, and fourth patients, maybe go to 1 day online. And then you can have either that best of both worlds or ultimately go online if you want to full time. I want to talk about the test a little bit, and I'm going to bring James on because I think that he can give some valuable insight. So essentially, these are kits. You look at the one on the left, the FIT 176. It tests all food sensitivities. I'm definitely going to go into detail on them. And I believe that it's a critical element to test for food sensitivities because they are the reason, in my opinion, or a main contributor to hidden and chronic inflammation. The gut barrier panel, I'm all about the gut. Everybody knows I'm a big believer in the gut barrier panel. So much new cutting edge material, data has come out recently to speak to if somebody has a leaky gut, they have a slippery slope of failing health. And now the new kid on the block, the cardiovascular inflammation test. I mean, I think it's great. I mean, when you really think about it, the number one killer in America and in the world today is heart disease. So the backlog is inflammation. And before we leave today, I'm going to show you how all three tests go together in a kit to really speak to health, ascertaining inflammation, and longevity. James, did you want to say something about the kits?
Yeah, no, I mean, I think as you rightly pointed out, from an online perspective, to give your patients the ability to run the food inflammation test, which now obviously includes, as Dr. Rob was mentioning, the gut barrier panel. So you're looking at immune health as well as inflammation via their diet. And now with the launch yesterday of our cardiovascular inflammation test, the idea is let's look at cardiovascular health as well, given the standard lipid panel. Generally 50% of patients who have heart attacks have a normal lipid panel. So the idea was to come up with a cardiovascular panel that would be more extensive than the standard lipid panel, given that doesn't seem to be a great way of checking out whether patients are going to have a cardiovascular event or not.
Outstanding. And to piggyback, the Fit 176 gut barrier panel covers all three lines of defense and immune system. So those people like myself who wrote a book, Immune Reboot, those people who really like to talk about immunity, the black box, if you will, you can now utilize the Fit 176 gut barrier panel as the three lines of defense and immunity. So very quickly, I'm going to throw these up. What's the problem? Why do we want to have these tests? My dad's like, 50 years ago, we didn't test. Well, you know what? The population, especially the American and really the world population now, is much more unhealthy. And one of the biggest problems is the consumption of ultra-processed food. 63% of our calories consumed in America comes from ultra-processed food. As the famed Jack LaLanne once said, if man makes it, I won't eat it. And there is your diet. And obviously we can individualize and personalize, take out food allergies, clearly take out food sensitivities. But I think one of the biggest problems is the consumption of sugar. The average American consumes 160 pounds of sugar per year. Sugar works with the reward center in the brain. It lights your brain up more than cocaine. Study was shown that mice, when they were offered sugar or cocaine, 94% took sugar over cocaine. Sugar leads you down a slippery slope of bad health. But not only that, you'll see with the CIT test that sugar is one of the backbones to bad cholesterol markers, insulin inflammation, high glucose, hemoglobin A1C, etc. And they may be the linchpin to all our failing ills. Of course, wheat consumption, caloric sweeteners, rise in diabetes, joint pain, too much consumption of medications in toxic and stressful world are very big contributors to overall failing health that we have today. So I kind of like this summary of potential factors and mechanisms linking ultra-processed food consumption with adverse cardiometabolic outcomes. We kind of just talked about that again, that the American diet, and I've been in the UK. The UK is not that far ahead of us, sorry to say, everybody, in the lack of usage of ultra-processed food. But the bottom line is, it's been stated that ultra-processed foods and cardiometabolic health, public policies should be produced to reduce consumption, and it cannot wait. So our failing health is really linchpin to the idea of poor food. Food, good food, can be a potentiator for health information. Bad food can be a potentiator for inflammation. And obviously the FIT test and the CIT test is based on inflammation. Time magazine in 2004 said the secret killer was inflammation. So much so, they had coined a phrase now called inflammaging. Inflammaging means inflammation that's causing us to age prematurely. With the advent in the conversation of the incisive topic, longevity, we want to quell to ultimately vanquish inflammation. My credo is to manage and modulate inflammation, and you're able to do it and use a baseline when you apply the FIT and the CIT test. Early detection is critical. Early detection of biochemical markers allows for early intervention and the ability to prevent diseases. Most people wait until the disease is there. It's already causing a problem. They don't do early prevention. Here's a factoid. 50% of heart attack patients have a normal standard lipid profile the day of a heart attack, which just goes to show, to piggyback on what James said before, where he said, you know, the standard tests really don't reveal enough. That's really speaks to that. You need more invasive tests. You need more tests that bring the bottom to the surface, if you will. One more factoid. Heart disease is the leading cause of death for both men and women. This is the case not only in the US, but worldwide. So what markers would I look for? What would I want to test for to have the precursors to this? Well, the cardiovascular inflammation panel. I think this is a leading edge test. I have yet to see a test in a blood spot to be as effective and as revealing. So remember, when we talk about total cholesterol, that'll be the first one. It's sugar, not fat, that raises your total cholesterol. And triglycerides come from carbohydrates that we consume. I've got some notes here. I want to make sure that I share everything with you. But total cholesterol is the amount of all the cholesterol in your body. It's both HDL, LDL, and the like. So total cholesterol is a standard marker. It's a great start. It doesn't tell us everything. However, direct LDL is the amount of cholesterol in the atherogenic low-dense lipoproteins. Notice the word direct. Most blood labs, unless you specifically ask for it, is calculated. There's a vast difference in accuracy between calculated. They're assuming you have like 400 triglyceride level to get a calculated LDL. This is a direct LDL. This should be start. It should be beeping. This is a game changer. High dense HDL. Remember, HDL, happy, it's heavenly, if you will. LDL, to remind our patients, it's lowly, it's lousy. We don't want it. Triglycerides. Triglycerides are elevated levels, increase cardiovascular risk by altering metabolism. I call them blood fats. So now you've got an improvement over the standard American, if you will, cholesterol, blood lipid markers. Then you get into the lipid ratios. You get the triglyceride, total cholesterol or HDL. Now that is actually a better indicator of the plaque impact. So when you look at that ratio, it's a plaque impact. Triglycerides over HDL or HDL over triglycerides, that's plaque forming patients that have insulin resistance. 90% of insulin resistant patients are undiagnosed. Believe it or not, the HDL ratio predicts this risk sooner than fasting glucose or even hemoglobin A1C. Lipoprotein A or lipoprotein little a. Basically, it's the sticky lipid. It's where turbulence is in arteries. It's actually the glue. So when there's an injury to the arterial walls, LP little a, it's genetic. 25% of Americans approximately have it. 40% of their family members have it. This is a critical marker. It's a one-time marker, but the interesting thing is, it says new data that says that statins don't affect it positively and may actually even raise it. There are some lifestyle hacks that I've done to see LPA go down, because remember, genes are not your destiny. They do load the gun, but your environment, your diet, etc., will fire the gun. ApoB, what a takeaway. You know, I have discussions with all my patients because I don't see the doctors in the local area ordering it. It is the best single cholesterol predictor of heart risk for a heart attack and stroke. Every particle of dangerous cholesterol is wrapped like in a suitcase. Walking on a boat, I'll give you my example in a second, and less than 5% of Americans have been tested for this. So ApoB, boo, B. Remember, if somebody went thumbs down, ApoA, it's a good thing. ApoB is a critical element. B is, I use the idea of a suitcase. I call it the Titanic. It's how many particles of LDL it's carrying to sink the proverbial ship. Glucose, it's a snapshot in time of what your fasting glucose is. Glucose is a good marker, but the hemoglobin A1C is one of my more favorite markers. I love the ratios of glucose to hemoglobin A1C that you can use. Hemoglobin A1C assesses the average glucose marker for a period of approximately 3 months, with an emphasis of 50% on the last month. Hemoglobin A1C is the standard marker to determine if we're metabolic syndrome, prediabetes, and or diabetic. So glucose and hemoglobin A1C are metabolites, if you will, or metabolics. What we mentioned before were lipids and inflammation, high sensitive C-reactive protein. It is a heart attack marker. It is common in pre-diabetics and diabetes. Believe it or not, one of the things that raises high sensitivity C-reactive protein is visceral fat. Visceral fat is fat over the viscera. It releases something called interleukin-6, and this raises high specific C-reactive protein. It is a critical inflammation marker. When you're looking at your lipid markers and your inflammation markers, which glucose and hemoglobin A1C is also an inflammatory marker, you want to understand that typically your inflammation marker will be elevated with your adverse cholesterol. You now have the perfect storm for plaquing. And homocysteine. Homocysteine is your stroke marker. A lot of doctors now have not discussed it as much. I think it is a critical marker to include because it tells you one of two things. One, if you're susceptible to stroke. 1B, that inflammation is elevated. And 2, you may not be able to methylate. And it's maybe as simple if this marker is high, you can share methylated B vitamins to attenuate a lot of the issues that come with high homocysteine. This slide is all the CITs on one picture. So you got your advanced lipid testing from your KBMO CIT, direct LDL and HDL-C, total cholesterol and triglycerides. You have your lipid ratios, your ApoB, your LPA, and then you've got your glucose, your hemoglobin A1C, your homocysteine, and your key inflammatory marker, HSC reactive protein. And I added these slides as slides of reference. And the reason I wanted to have this is when someone goes over, for me, when I watch other people's webinars, I typically stop. These give you the ranges in their guides. So obviously, if something's green, you're in a good area. If something's yellow, you need to slow down. If something's red, put on the brakes. It's great that it's color coordinated. One of the things that I really appreciate is the ease in which I'm able to explain to the patients what they have because of the color coordination. How many times have people come in and said to you, I don't know what these numbers mean, I'm out of range, but they're not necessarily really out of range. But the green, the yellow, and the red are quite evocative for everybody. And lastly, there's your homocysteine. So very quickly, what supplements might help? I really appreciate what James does in that he gives me the opportunity to share some insights into alternative protocols. So here's my blood sugar inflammation protocol: low sugar diet, eat clean, eat organic foods, GPS, no gluten, no processed food, no ultra processed food, no sugar, DNA, no dairy, no nicotine, no artificial sweeteners. All blood sugar metabolizes alpha-lipoic acid, chromium, taurine, acetyl L-carnitine, berberine, which for me is better than Ozempic, probiotics, and omega-3 fatty acids. If you have inflammation markers that are elevated, here is my recommendations. Pro-resolving mediators, they allow for the resolution of inflammation: vitamin C, vitamin D, ginger, boswellia, curcumin, B complex, magnesium, essential fatty acids, and of course, a healthy diet. So let's keep our sugar, let's keep our processed foods down, let's eat more essential fatty acids, let's eat a better quality protein. That is something also that you add with the tests on your virtual consult. And lastly, if you have high homocysteine, talked about it before, B vitamins and cholesterol markers, if you're not going to opt for the medications, niacin, red yeast rice, phytosteroids, etc. And I'm going to have James come on here. He's done a great job. We utilize a lot of products from Nutridyne and Biotics. However, a lot of people have asked for the ability to get the test. We now have, or James has, a relationship with FullScript. James, do you have a moment to speak to this?
Sure. So again, with the and Dr. Rob will go on and talk about the gut barrier panel where we kind of had this originally, but I'm sure as we get more protocols around the CIT test, we'll add things to here as well. But the idea was to try and make this seamless for all our providers, on the basis that what we're trying to do is make sure that when we have a test result and there's a protocol, that you can just link up with some of the good supplement companies like the Biotics, like the Nutridyne. But FullScript is that kind of third leg of the stool, as it were, where they can enable you to be able to ship directly to your patient. So the idea is, again, back to Dr. Rob's whole seminar today, talking about remote. With the FullScript opportunity, it means that you can send things directly to your patients versus having to stock them in your front room or in your bricks and mortar, as the case may be. So the idea here was to have some FullScript supplements and protocols that they've embedded into your store, which you can then click on and provide for your patients. So that's what we've done with the gut barrier panel and the food sensitivity test. And we will be, probably watch this space, adding that now with the cardiovascular inflammation test. We did a webinar on this with FullScript last week, and I think we're lining up Dr. Glad, who's the CSO of FullScript, to go through his experiences working with KBMO, but also in parallel with his great protocols that he's created as well.
Outstanding. Thank you. So now, as James set the table for me, if you will, let's talk about IgG and C3D food sensitivity, or if you will, the FIT 176 test. So as everybody knows, who has used the test or just starting to use the test, this test is very unique in that it's based on using IgG, which, as we all know, is an antibody. It not only does IgG, but like other companies, it does IgG 1 through 4. IgG3 is critical because antibodies, and I never knew this till I started to use this test, can actually stimulate inflammation. In that, IgG3 is actually stimulating the complement cascade in the innate immune system, and it's based on the C3D molecule, which is the most stable inflammatory molecule in the body. So for an epigrammatic finish, IgG, C3D, this is the only dual purpose test, dual pathway test that I've seen that's effective on the market. So the immune complex formation, essentially when you're testing for C3D, you're testing for inflammation. I use this picture all the time. Hopefully this really reveals an idea in that when you have inflammation beyond your gut, if you have certain markers that are there for a duration of time, you could also have inflammation at the gut level and or autoimmunity at the gut level. These immune complexes, which we're testing for, actually once again lead to inflammation. So this is a quick slide in that the complement system is basically a part of the innate immune system. It's an older evolutionary part of the human immune system. And the bottom line is the FIT technology, without question. If you look at the left, it shows that many, and it really shouldn't be one grab. It should be a half a grab because most people use IgG 1 and 2. When you look on this side, you see the grab of IgG 1 through 4 and C3D. So you're seeing a dual purpose test. Nothing is more effective. Now, what does it really say? Let me put it in layman's terms if I was talking to a patient. The test is showing that when you consume this food, the sensitivity to the food is lighting up inflammation in 2 of your inflammatory pathways. It's producing antibodies and it's raising inflammation because the antibodies can't overrun it. So therefore, we've got to address it. And how do we address it? We're going to remove the food for a small period of time. So again, what have we talked about? The client report. I like the client report a lot. Again, take a good look. So here you're seeing red, which is a +4. It's really showing an elevation of IgG and inflammation response. The orange would be a +3, and the yellow would be a +2. Those all have to go. Now, when I say go, taking away a food sensitivity does not mean you take it away for perpetuity. You take it away for a period of time. You try and treat the problem, and then you retest and or reintroduce. But some of the hidden gems, and sometimes we don't talk about this enough, it's also testing for food additives like aspartames, benzoic acid. I just had a bodybuilder who told me he eats clean food. As you guys all know, I practice brick and mortar and online. And in his protein powders, he had a lot of aspartame. How's this? James is now testing for chia. He's using chia seeds, rocket ships for omega-3. The only problem was he has a food sensitivity to chia seeds, etc. So we have to, and we just started to make the tweaks to enable him to decrease his inflammatory status. So that's the FIT 176 test. The gut barrier panel is interesting in that we're testing for IgA 1 and 2. So IgA is an antibody that's at the mucous mucosal level. So if it's positive, and this person has a few positives there, you're talking about inflammation like Candida and zonulin at the gut level. Whereas when you're looking at IgG 1 through 4, we just talked about that a little, just to add a little color to it. IgG 1 through 4 is the full IgG antibody. It's over a period of time. It usually takes about 21 days or longer to have an IgG released. You're also combining that with C3D, once again, the most stable molecular molecule in the body. But what does this gut barrier panel mean in a nutshell to a patient online? Well, one, they can see it, it's nice and colored. Two, Candida. Candida is a yeast. When you have an elevation of a yeast, and that's showing that it's elevating IgA and IgG and C3D, so it's saying that you have an elevation of yeast, both at the gut lining and for a period of time. We call that, or at least I'm calling that now, SIFO, small intestinal fungal overgrowth. So James, you're allowed, as far as I'm concerned, to call your test a SIFO test. And this is very revealing on a virtual consult. Zonulin, when you see the elevation of IgA 1 through 2, you're seeing that zonulin, which is a protein enzyme found by Dr. Alessio Fasano, is positive at the gut level. In a nutshell, here's an epithelial cell, here's an epithelial cell. They come together, they make a tight junction. They call this paracellular junctions. If zonulin is elevated, it pulls apart at the gut level. If occludin is elevated, the structure of the fibers are pulled apart. So zonulin is pulling at the gut level, but it means that it's an early pull. LPS, vastly different. There'll be a couple of slides. We'll be very quick, brisk when we go through them. LPS is an endotoxin. It holds gram-negative bacteria on the inside of the intestinal wall, gram-negative bacteria like E. coli. So LPS shows a positive to IgA 1 through 4 and C3D. That positive is showing that you have an endotoxin that's been floating around the bloodstream for a period of time, poses a detrimental effect to one's overall health. They're direct binders and they can hold on to specific structures in the body. So zonulin, real quick, zonulin's elevated from any kind of gluten, intestinal bacteria. Zonulin is a beautiful marker when you talk to your patients in that it's a systemic inflammatory marker. Many diseases like celiac, non-celiac gluten sensitivity are associated with it. And believe it or not, even obesity. Occludin is the structure. Basically, occludin opens in response to zonulin. Elevated levels are associated with the progression of intestinal permeability. And the last part of the gut barrier panel, which I know everybody knows about, is that LPS. LPS acts as a strong stimulator of the innate immunity in humans. Now, LPS also crosses the blood-brain barrier. Now, interestingly enough, LPS is a direct reason where you have a leaky gut. You now release amyloid beta, and these amyloids float to the brain. And in addition, Candida has shown also to create inflammation in the gut and also past the brain. Many of these things that damage the gut barrier will also damage the blood-brain barrier because it's made up of the same epithelial proteins. And lastly, the reason I want to show you this is not to give you a biochemistry test, but this bridges the gap between your gut barrier panel, your FIT 176, and your CIT test in that LPS, when it's released, attaches to toll-like receptor, which stimulates NF-kappa B. It damages the mitochondria and also releases the activation of NLRP3. All I'm saying is it's stimulating all these interleukins. However, LPS, if it's positive and you did not take the CIT test, you're definitely going to want to, because LPS stimulates toll-like receptor 4, which also transduces a signal to toll-like receptor 2. Toll-like receptor 2 is the receptor that stimulates atherosclerotic plaque. It has been stated that the release of LPS from the gut increases the incidence of heart disease by 3 times. So now you're seeing how the gut can damage plaquing, and there's a tie between the tests, which really strings the patient together in a very nice way. So essentially, why do we use the FIT test? Well, it's a dual pathway test. It tests for both acquired immunity and innate immunity. The immune complexes that cause inflammation are underlying problem for many conditions seen day to day. Here's the takeaway. Food sensitivities, inflammation, and gut permeability are all in one test in the FIT 176 gut barrier panel test. Now, what really caught my attention first to the KBMO tests was the IRB test. This was an irritable bowel syndrome clinical study that was done. And interestingly enough, IBS, which was a visual analog scale for discomfort, you showed that when you took away food sensitivities, you saw a precipitous drop in the intervention group versus the control group. Nothing else was done. So the patient felt better. That's a good thing. Now, on a virtual consult, I use a lot of, and I will share it with James so he has for a follow-up email. There are a lot of positives that come out of the idea of testing the numbers, and especially the numbers in IBS severity, headache, back pain, etc. Now, interesting, the FIT test showed that if you remove the food sensitivities, homocysteine dropped dramatically in the intervention group versus the control group, just from taking a food out. Now you're seeing the synergy between the tests. And then C-reactive protein, you see a 5 times decrease just removing the foods. Nothing else was changed other than removing food sensitivities in this IRB study. So FIT test conclusions, measures 176 foods, colorings, and additives, dual pathway detection technology, IgG 1 through 4, and the complement. The complement we now know generates inflammation. It's a unique gut barrier panel that's now included. It tests for candida to see if you have a yeast overgrowth, to see if you have small intestinal fungal overgrowth, in my opinion. It uses an anti-zonulin antibody, which I think I'm going to have James come on in a second and really hammer that point home. It's a marker of gut permeability. It also tests for LPS. It's excellent clinical outcomes backed by IRB approved clinical studies, and it's a finger stick. So for me, I'm not able to draw blood. However, how can the patient draw blood? It's a perfect add into a virtual consult to get blood work. James, would you like to just take a moment on that anti-zonulin antibody?
Sure. We were kind of, I guess, underawed by the quality of the zonulin protein tests out in the market, on the basis they were cross-reacting with a couple of things: haptoglobin, properdin. They were generally showing a low positivity rate, and they really didn't correlate with clinical outcomes. So, with armed with that information, we kind of worked with Dr. Alessio Fasano to kind of uncover what were some of the causes of that, and then worked with our very own Dr. Brent Dorwell to kind of solve those problems. So our test now does not cross-react with haptoglobin and properdin because, as this slide suggests, we developed an anti-zonulin antibody from going back to basics. So we made sure it doesn't cross-react. It's very stable. So it's stable for up to 2 weeks, whereas the protein assays are generally showing different answers from morning to afternoon. And then what we've seen now from a positivity rate, it correlates really well with the data that Dr. Fasano had published in the Lancet in early 2000. So again, rather than just saying we're a kind of technology company, we've actually taken that knowledge and applied it to somewhere like zonulin, which was a marker which everyone understood and believed in, but there was really no good assays out there to actually to tell whether your patient has elevated levels or not. So I think that's where we solved that problem. And rather than just leaving it as a single marker, worked with the likes of Dr. Rob to say, what are the other markers to put around that if you think that leaky gut's a continuum, to give you a really more accurate way of trying to screen your patients for leaky gut versus just a single individual marker. Because as ever, it's generally life is more complicated and nuanced than just a single marker.
Outstanding. Great job. So one of the things I like as an add-on is the phone app. And the reason I like the phone app is patients can't remember their results. So the phone app they carry, everybody carries their cell phone around so they can look and remember which foods not to eat. Also, There's diets there that KBMO supplies. If you don't want to supply a diet, you have that option to hand them a diet. The food sensitivities are obviously taken into account. Very quickly, the 7R program I've devised, and in the interest of time, you guys have seen this, a 7R program to help with gut health. This is specifically if you have LPS. So you reset the diet and you would be based strictly on your food sensitivities. You would remove unwanted pathogens like using berberine, oregano oil, serum bovine immunoglobulin, biofilm buster. You replace with digestive enzymes, stomach acids, and bile. The fourth R would be regenerate intestinal mucosal lining. So you would use things, the plethora of nutrients that are pleiotropic that allow for anti-inflammation and also fixing damage in intestinal mucosa. Reinoculate would be a pre and probiotic. This should be reintroduced and retest. This is where you may want to use, and I do retest with the fit test all the time. And then I reintroduce the foods as a double check, and you'll feel very robust on your results. And lastly, you want to retain your health and GI integrity. If you had to take away gluten and you can't eat gluten for argument's sake, it makes no sense if you feel better to put the gluten back in. Here's some protocols if you have an elevation of candida, antifungals like caprylic acid, oregano oil, berberine, garlic, serum bovine immunoglobulin, probiotics like lactobacilli strain, zonulin and occludin. You would be specific probiotics, zinc carnosine, L-glutamine, collagen peptides, curcumin, glucosamine HCl. And let's talk about the KBMO test kit advantages. One, it's a dry blood spot. It's not messy. Anybody can do it. The patient can do it in the confines of their house. It's validated against serum testing. It's a 93% plus agreement. It's stable for 14 days. Patients gives the patients another major screening tool to assess overall health and longevity. Speaking of which, health and longevity, look at the intersection and health and longevity with the 3 exams. You've got the food inflammation via the FIT test. You've got the immune health via the gut barrier panel. You could also add the FIT test in there as well. And now you've got the cardiovascular health via the CIT test. So you see all 3 fit together, in my opinion, in a nice kit. And I call it my home inflammation kit. Lastly, before we get to some questions, test and don't guess. So that's why I use the test. So I wrote some things I wanted to share when James was talking. You want to provide online clear instructions to patients on how to conduct the tests at home. This may actually even include step-by-step guides, videos, or a virtual demonstration. Now, all these things, there are videos on how to do it on the KBMO website on how they could perform the test. Educate your patients on the importance of the test and how they contribute to the overall healthcare. This actually will increase their compliance and engagement in their own health management. And KBMO constantly updates its tests, updates its information, its demands, and really enables people to work in more in depth in a health concern. So James was magnanimous enough, without question, to offer a discount. You've got the FIT 176 test, including the gut barrier panel, at $200. You have the cardiovascular inflammation test at $150. Here's how you could do it. And real quick, let's get to some questions. James, would you prefer me to leave this slide up, or would you like the question slide up?
Either's fine. So let's
I'll switch back and forth.
Yeah. So we'll see what we got from people. There was some kind of discussion in the chat here. One of the questions that we had was if you had an elevated candida result in a stool test, but necessarily negative in the FIT test, what would you say to that, Dr. Rob?
Yeah, I'll be honest with you. I think the poop test has its place. I find the serum test for candida and zonulin vastly more accurate. And I think that's really the answer. There's nothing wrong with that, but I will always go by serum before anything else, especially when it comes to zonulin and candida.
Another good one here from Philippa. Are trigs the same as free fatty acids?
Are trigs? Triglycerides, free fatty acids. Okay. So triglycerides is free fatty acids. They're a little different. They're the blood fat in your body.
Okay. The other one here is, do we have a protocol specifically for LP(a)? What I was just saying there, Terry, we're developing a provider's guide as we have for the FIT test around the CIT test. So there'll be some examples of suggestions there. Dr. Rob, I think you mentioned that you'd seen some biohacks and things around LP(a) to try and get that down.
Yeah, I've seen it drop down. Now, I'm not going to say I've seen the other markers drop down dramatically. This one's a little bit more stubborn, if you will. So I have found, of course, diet is always the backbone. Diet and exercise, those go synergistically together. They do work in concert with proper supplements, and that would, believe it or not, be omega-3 fatty acids. Shocking as it may seem, acetyl L-carnitine. Remember, LP(a) is included in your ApoE-B marker. So it's a lipid protein.
Okay, good. Good information there, which I'm sure everyone was aware of. Melissa here is asking, is the discount available for existing KBMO providers? Absolutely. If you want to rerun the test or you haven't run yourself for a while, then by all means, try the test. Another one here for Dr. Rob from Silka. Do you find daily probiotics safe for all generations?
Oh, wow. I always get nervous about the word all. My wife says, be very careful to say all-encompassing. I believe that the bulk of people will benefit from a pre and probiotic. There are some probiotics that I would try to avoid if someone were to have a leaky gut. So let's assume that someone has a leaky gut. If you look at my 5R program, I start making sure that by the 5th R, they re-inoculate that. However, if we had a little bit more time, or in the future, if you're able to spend some time with me, I would share some insights in that I would always start off with a yeast, like a Saccharomyces boulardii, or a spore and an endospore like Bacillus subtilis, Lactobacillus acidophilus, and B. lactum are also excellent choices. You want to be careful with somebody just giving a probiotic, because if the gut is leaky, those bacteria which don't have great adhesive capacity can pass through the gut and get into the bloodstream. Remember, there's something that I wanted to say that the KBMO test says that we don't say enough. Talked about paracellular tight junction damage with zonulin included. If LPS is expressed and zonulin included is not, you now have a transcellular issue, which is going to take longer to heal. And that's the beauty of the test, because it can be so revealing.
Okay, perfect. Question here about, would KBMO mail out a kit to client instead of going through FullScript? So FullScript is only linked to the supplements. It's not linked to the kits. So Renee, you'd sign up with KBMO, and then we can show you how to set up a way that we can drop ship kits directly to patients. So that's no problem at all. And we'd be happy to kind of walk you through that and show that how that works. Another one here on KBMO. Can I request quantitative results to follow patients' progress instead of obtaining only qualitative, observing on your charts in red and green? I guess what we would say is yes, but the reality is you're going to see a difference in that color coding is numbered as well. So it's 4, 3, 2, 1. So again, you'll definitely see a numeric change there. So that's something that you would see in terms of, happy to send you a report, Martha, to kind of demonstrate in that a bit more detail. Philip wants to know, are you sending over the slides? Yep, Dr. Rob normally puts that in a PDF form, and then we'll mail that out to everyone as well. And then the question here about LP(a) again, the way the report comes back, if LP(a) is out of range, suggestions are made on the report. The recommendations are based on current literature, and the report is dynamic. So that was from within KBMO in terms of the answer on dealing with that. James Panther to everyone, please address the LPS only transcellular question mark.
I had a feeling that was going to blow up the phone lines. So in a nutshell, I mean, James, if we have a moment, I could go get a slide and let's do it. If I'm able to. Actually, I'm not. Sorry, guys, I'm having a little trouble getting out of the slide deck. I'll try one more time. Okay. So everybody's going to see my laptop desktop. Please don't laugh.
Tidy mind, tidy laptop, and all that kind of stuff.
Yeah, that kind of deal. But, and I know I really haven't discussed it in the test before, and I should have. So take a look at this. There's a paracellular pathway and a transcellular pathway. That paracellular pathway is the tight junction. That tight.
It's not up on the screen yet, Rob.
I think, all right, let's new share. Share. We got it?
Yep. Perfect.
Okay, beautiful. So the paracellular is on the right side. It's the tight junctions. Everybody can see me. That's when the junction's tight. So when zonulin and occludin are compromised, you have a damage in the tight junction. You could have LPS go through the tight junction. It's conceivable. But what happens if zonulin and occludin are both negative, but you have a positive for LPS? It didn't get through the tight junction. It got through the transcellular pathway. It got through the epithelial cell. And that's a distinction that I think that, James, to be honest with you, I haven't made it enough. I really think in the future to really make it, because your test reveals that. And LPS is going to take a longer period of time to help ameliorate the damage to the epithelial cells. James, does that help?
Let's see if James responds to that.
Yes, it certainly does. Thank you so much.
Perfect. There you go. Thank you, James, for coming online. Excellent. So yeah, so that's a great question. As I say, it's probably something we were aware of, but we just Dr. Rob's point, we hadn't probably articulated fully enough. So I think that's a great slide, Rob.
Incidentally, it's a very common thing. I found a patient who had a 1500 calcium score up from 1200, even though his markers were excellent. Blasted him with all the tests, including your gut, and his LPS came back positive, and I'm trying to straighten that out. And actually contacted KBO's consultants and were very helpful trying to get that explained. But this goes even further. Thank you so much.
Well, look at the and I don't want to belabor the point. Look at the TL4 getting stimulated by LPS, going to TL2. I have a slide on that, but I think that I don't want to play too much. But in our next talk, maybe, maybe James, maybe that's the link. Maybe we'll talk about how LPS could be the link, the unseen link into the CIT test or something like that, because that's new for them. And that's great. And it's very, for me, it's exciting because I was actually very quickly on a plane with head of a cardiologist from a pretty esteemed university and a hospital in New York City. And he was looking at literally this slide deck. And he was just like, wow, I think that's a great tie. It's not something, and it's something I know about, but it's not something I would test for. So look at the built-in advantage, and then look at the built-in advantage that you can get in all 50 states, intercontinental, international, etc. And that's the big thing. I think the test is the driving force to want to do these virtuals. But remember, just start promoting it and letting people. And I'll make an offer and let James know. Maybe he and I will put together a quick piece of like 5 or 10 steps, on how to, basically the title of today's webinar, on how to implement the KBMO tests into a virtual online, if you want to recap.
So there's a quick question, well, not a quick question, a question here from Scott Brunberger here. Yep, there's no limitations on the existing accounts in terms of that promo code. I'm happy to kind of offer a couple of tests for people who are existing clients. And then to confirm, thanks, with Saccharomyces strains, is it okay with a positive candidate IgG or an IgA?
So, yes, it's a great question. Saccharomyces is yeast. It's not a problem. It's a really good question. And there was new data, I think it came out 2 weeks ago, James and I talked about it, where an increase in Candida really created more gut inflammation and actually was a leading cause, or one of the leading causes, for long COVID. Candida can pass the blood-brain barrier as well. in that it passes the blood-brain barrier and it can stimulate the microglial or microglial 1 in the brain and really cause a lot of inflammation in the brain area. 70% of women have that microglial 1 turn on. So these are all things that you can do in a consult when you're comfortable like this. I mean, think of what you're doing right now as virtual. It is. Look how comfortable we are. I mean, we could be wearing our pajamas. I could be wearing my Met hat because I'm a Met fan and not a Yankee fan, etc.
Good. So I think oh, you've started something here. We've got Yankees going on here now, but
Thank God he didn't talk about Manchester, right?
exactly. So I think, yeah, that seems like all the questions. Unless we've got Philip, unless someone has tested sensitive to yeast. So I think that must be regarding the question from Scott. So that's fine. I think we're all good. Good. So, well, thank you, everyone. Thank you, Dr. Rob. That was great. And again, thank you for the freewheeling nature of the Q&A, which I think is always a great experience to hear you go through all these things. So, so thank you very much indeed for that. And so hopefully everyone's managed to pick up some clinical gems as well as business gems about how you go remote and some of the opportunities there in terms of combining your brick and mortar and virtual practices. So thank you again, Dr. Rob, for that. Very much appreciated. We'll get these slides out to everyone who's been on here. And again, thank you all very much indeed. And as Silke and a number of you have put in there, we wish you all very happy Thanksgiving to you all as well. So thank you for your time, and we'll be having more of these coming probably in the new year. So thank you all for your time, and happy Thanksgiving to everyone. Thank you again, Dr. Rob. Much appreciated.